Good morning, everyone. Welcome to the Stanford Medicine COVID Town Hall number 5. My name is Andra Blomkamp. I'm the chair of the Department of Emergency Medicine, and I'll be moderating this session. We're about 3 weeks, a little tad over 3 weeks after the shelter-in-place order, and we have a slightly different format for today's town hall, given the feedback that you have given us, both with questions and suggestions. We've invited some additional experts today to discuss the issues that are very pressing for you, and then we'll do the questions per usual that have been submitted previously, and then also the live questions. So today we have our Stanford Medicine leadership. Great. We also have some new panelists, including Luann Smedley, Associate Chief Nursing Officer for Stanford Children's Health, Dale Beatty, Chief Nursing Officer, Stanford Healthcare, Bonnie Maldonado, who we all know, Senior Associate Dean and Professor of Pediatrics Infectious Disease, and then Nigam Shah, Associate Professor of Medicine, Bioinformatics. And he'll be starting today with a presentation regarding modeling about COVID-19.
Thank you, Andra. So today what I would like to share with you is how modeling can help us make sense of what's happening around us. So for example, let's look at a fine model from the Institute of Health Metrics and Evaluation in Seattle. And as we can see, we're looking at the model output as of April 5. And you'll see that the peak is around April 26, with a median estimated bed capacity need of about 12,000 beds and a range of 1,500 to 27,500. The way this model works is that first it projects the estimated deaths that might happen in a region, and from that back calculates the number of beds and other resources that might be needed if that were to happen. And as you can see, it gives a pretty grim estimate for California. So now if you look at the model on the next day, April 6th, when the authors factored in the input regarding social distancing and its effect, you can see that the model now predicts a peak at about April 14, with a significant reduction in the bed resource needs ranging from between 4,500 to about 10,500, or about 2,500 to 10,500. And what I hope this illustrates for you is that models rely critically on having accurate inputs. And in this case, we've seen that incorporation of this one extra input drastically changes the output. Now, what that makes for resource planning challenging is that if you were assigning capacity for California, where would you put these beds? Where would you allocate the additional ventilators? So when you see a model output in front of you, what I would encourage you to ask are these following 4 questions. What are the inputs to the model? Is it based on death rates? Is it based on confirmed cases? Is it based on hospitalizations? What are the assumptions about the prevalence of the disease, for about the transmission rate, the R0 and growth rate and so on? Then there's the equation, or sort of the structure of the model. There's some that are statistical simulations, some that are proper epidemiological modeling of the scenario. And then finally, you want to ask about the uncertainty of the outputs. That what is the range of uncertainty in where the peak is? How much lead time does the model give you? And what is the uncertainty in the degree of resources you would need? The point is that all of these things need to be done at varying levels of geographical resolution, ranging from your institution to the city, to the county, to the state, and nationally. And we can't assume that the rates and assumptions that are valid for one place will be valid everywhere. So in order to address this situation, what we've done at Stanford is that we've created models that would help you estimate bed resource capacity, ventilator use, PPE use by your local county, by your institution. And we've made these available publicly, and the URL is at the bottom of the slide in front of you. And we would like to share these so that you can plan your own hospital's resource needs, as well as your for county and region. And with that, I would like to bring it to the closing point that I want to make, which is that in order for models to be useful to us, we need to feed them with accurate inputs. Models are only as good as accurate inputs we give them. So we need to reduce the uncertainty in the inputs, the assumptions, and the outputs. The only way to do that is by collecting the right data. and by collecting it fast, and by collecting it nationally.
Thank you, Nigam. I want to thank particularly you and your team. I feel like all of us want information. We feel better with information, and you've been able to provide information that's given us the capacity to understand this disease and what we need to do to prepare for it. So thank you so much. For the first question, actually to you, is the Bay Area was the first to adopt a shelter-in-place order. And we've seen now what we've all been waiting for is sort of that flattening of the curve. What do you predict, or what can we model for when those restrictions are lifted?
It's very difficult to say when we should lift restrictions. The one thing we can say is that when restrictions are lifted, we will see a second wave. The size of that will depend on our ability to correctly estimate how many people are already immune, our ability to rapidly test people at the front lines, and to do contact tracing and containment. And all of those things are crucial for us to manage the second wave. Without a vaccine, if we lift everything right away, there will definitely be a second wave.
Okay, thank you so much. The next question goes to our Stanford Medicine leadership. Since we do not seem to be getting the surge and things seem to be fairly steady, what are we doing to assist other local or national hospitals who seem to be in need?
Well, let me actually start with that question. I think one of the things that we've seen, we were very fortunate to have one of our own faculty here developed one of the early tests that actually could assess whether individuals had COVID. We actually have been able to, throughout the Bay Area, assist hospitals throughout our area and even our region in being able to do the testing that was in some cases delayed by other resources. So incredible in terms of being able to offer that. At the same time, as we even look nationally, and I've had several contacts with colleagues from around the country, other CEOs, that we've been able to help point in sources of PPE and other things that are being done. And so how could we assist those that certainly are going through more challenging times than we have now? And I'm sure as we look at other things like ventilators and the things that are actually some of the slowdown in this area, it'll allow us to even assist further as we get farther down the road with this. I'm sure Lloyd has other thoughts.
Well, just as David mentioned, we were among the first to have a so-called RT-PCR test to detect the virus and to introduce it here in the Bay Area. We also have been among the first to introduce a serology test, that is an antibody test, to look for the presence of an immune response to the virus. As Nigam mentioned in his remarks, as we move towards thinking about how to come out of shelter in place, it's going to be very important to determine what proportion of the population has developed an antibody response to the virus. Now, that doesn't necessarily mean that those who have antibodies are going to be immune, but the presence of that immune response is the first step towards evaluating when it's safe to begin to have more social interactions. And I'm pleased that we were among the first to develop it and that we're approaching this very collaboratively with other institutions in the Bay Area and beyond.
Thank you, Lloyd. In addition to what David was mentioning, David and I, as hospital leaders, we are on the phone constantly on conference calls with our colleagues across the country in terms of helping our legislators understand the impact that this crisis is having on all of our hospitals. In children's hospitals, as you know, we're not as impacted directly in terms of the number of patients, but we have to participate equally in terms of reducing the burn rate of PPE, preserving our capacities for that surge that we keep talking about. And so we participate, as Nigam was just talking about, providing those accurate inputs so that the modeling is even more accurate as we look forward to the impact that the crisis is having on all of the hospitals across the country.
Thank you so much. So Luann, is SHC or LPCH suffering a nursing shortage? And if so, are we accepting applications from the California Health Corps?
Thank you, Andra, for that question. Fortunately, we are not seeing a shortage of nurses on the front line. Several weeks ago, under the guidance of the CDC and CHA, we made the difficult and thoughtful decision to cancel our elective surgeries in both organizations in the event we saw an increased volume of COVID-19 patients. This has freed up some additional staff, and both organizations have developed a labor pool for those additional staff to serve in alternative roles to support the event. Over the next few weeks, we will be monitoring the event, if you will, and being thoughtful about planning and capacity.
Thank you so much. Bonnie, so as an emergency physician and with my team on the front line, I'm obviously worried about healthcare providers in general contracting this disease. And can you say a little bit about what we know about its transmission? And is it because of lack of PPE? Is it lack of social distancing? What can we blame for this?
Yeah, I think that still comes up around what the route of transmission is, and we are still looking at the models that NIGM and others have provided, as well as some of the other epidemiologic evidence. And we still feel very strongly this is primarily, if not uniquely, just a droplet transmitted disease. And we are very heartened by the fact that across the country, when we look at what's going on with healthcare providers around the country compared to our institution, we are seeing extremely low levels of infected healthcare workers. And the evidence all points to the fact that those are all community acquired rather than hospital acquired, or acquired with when there was lack of proper PPE. So the fact that we are providing proper PPE for everybody in the right situations and getting that message out to our providers and our front-facing staff makes me feel very confident that will continue to be the case.
Great, that's great news. I know that having PPE is one thing, but then also knowing how to use it appropriately is another. And I've been personally grateful for Stanford's efforts to make sure that all our providers know how to wear PPE and know how to take it off, because that is a significant point of potential contamination. Dale, I'm concerned about nursing ratios and loosening nursing ratios, particularly in the ICU. What is Stanford what is the stance on that? How is it looking at that? And can you explain just nursing ratios in general for those of us who might not understand it?
Sure, Andra. We're fortunate here at Stanford Medicine Enterprise that we actually are maintaining our nursing ratios, and in fact, in many cases, we're exceeding the ratios. For COVID-19 positive patients, we are staffing them 1-to-1, and for PUI, we're staffing 1-to-3. And then adjusting per acuity. I just wanted to highlight Luann's comments that the float pool, labor pool has been essentially very important for us in terms of being able to maintain those ratios. And then we're watching the modeling that has been discussed prior to really articulate what our projected needs may be in the future. I also just want to give a shout out to all of our nursing colleagues across Stanford Medicine. It's because of your dedication and your resiliency that we're able to maintain these ratios. Thank you.
Thank you so much. Lloyd, our Stanford serologic test has been on the news quite a bit. How many tests do we have, and what is the strategy for implementing them?
Well, thank you, Andra. As I mentioned in the introductory remarks, we have a laboratory-based test done in our certified laboratory that rolled out this week that is used to test patients who are healthcare workers or who are recovering from COVID-19 infection to look for the antibody response that we hope occurs in response to a COVID-19 infection. That test is very important in terms of looking at the prevalence of antibodies in the community. Also, there was a research study done and reported this past weekend that looked at a large number of patients throughout our region to see, using a commercially available kit, to get an indication of what proportion of a broad-based population might have antibodies. So we've had a research study, and now we have a clinical study returning results to patients and physicians that clinical study moving forward will be a very important input into determining the factors we need to know before going back to work.
Okay, wonderful. Thank you so much, Lloyd. So now we'll be transitioning to the live questions, and then we'll move forward with those until the rest of the session is over. So to NIGM, based on models of viral spread, when do you anticipate us being able to return to a relatively normal work situation?
So it's a great question. That's a question I ask myself as well. I think the models of viral spread in and itself are not sufficient to answer this question, because aside from models of spread, we also need the ability to do contact tracing, the ability to test people at the front lines and do it fast. Without those two things, as Bonnie was saying a little while ago, the virus is out there and it will spread. And so while it's tempting to model a mathematical equation that tells us that transmission is now down to a certain level, therefore we can all go out. I think that's a little bit wishful thinking. We have to be open to the fact that until we get a good handle on basic epidemiology, on serology, and on contact tracing, our models are not going to be accurate enough to be able to say when can we go back. They can definitely tell us what the second wave and its size will be, but getting to that timing requires much better inputs.
Okay, thank you so much. Bonnie, what does Stanford's serologic test confirm, or does it confirm immunity to COVID-19?
Yeah, that's a great question. It's a new test. I think we're learning a lot more about the immune response to this brand new virus. So the answer is that we really don't know much about what these antibodies really mean at this point. So for example, we know that the antibodies tell us that somebody was exposed to the virus at some point recently, we assume, because the virus hasn't been around that long. What we don't know and what we're studying right now are a number of other things. That is, number one, does this antibody mean that you're protected from future infection? Number two, if you have that protection, how long does it last? Will it last a long time? For example, with measles, you have lifelong immunity once you've developed the disease or you get a vaccine. But that is not true for some of the other coronaviruses. And then the third question, which is equally important, is if you develop immunity, can you still get infected but not get sick and therefore transmit to other people? So we really need to answer all those questions, and we have people working very hard right now to try to take some of these blood tests, put them into the laboratory so that we can try to understand exactly what an antibody test means for the individual and for the community as well, so that we can use this to predict a lot of the things that Nigam has talked about around who's infected, what's the likelihood of spread, and many other questions that'll get us back to life as we aspire it to be.
Okay. Thank you so much. I think that what's new about this is a new virus, right? And putting in those inputs is particularly difficult, and that's why the continued research and modeling is so important.
Yes.
So to Dale and Luann, I've always made it a practice to change out of my scrubs after work and wash them when I get home. I haven't seen any official guidelines regarding this. Am I being overcautious?
So we've been looking at all these issues very carefully, and we really appreciate the input and concerns that our nursing staff and clinicians and faculty have brought forward. We really believe that there's very little transmission through cloth that can take place related to scrubs. That being said, we do recommend that you do take them off and wash them at home prior to going into your home. And then we also recommend that you wash your hands prior to leaving the hospital and also when you get home as well.
Okay. Great. Bonnie, what is the sensitivity and specificity of the new rapid COVID test being used here at Stanford?
Again, very good question, and unfortunately, not a definitive answer, and I'll tell you why. We use these traditional epidemiologic terms of sensitivity and specificity to tell us what a true positive is and a true negative is. The problem with that definition in the hypothetical world, you have a gold standard to compare it to. So you have a known infected, truly infected person, and then you use that to figure out whether the test can predict that patient. In reality, what we have is the opposite. We have a test, but we don't really know whether the patient is truly infected or not. And we're using the test itself as its own gold standard. So in that situation, what we're trying to use really is something called the negative predictive value. I think for us, that's much more helpful. That is, what is the likelihood that a negative test really means that somebody is negative? I don't think we're as concerned about what does a positive test mean. We're much more concerned about the negative test. Given, and I won't go through the statistics here, but essentially the formula for calculating a negative predictive value is really dependent on how many people are infected in the population. And since that number is actually quite low, I know it looks like there's a lot of cases, but we really think the number of people truly infected in the entire population, especially in the Bay Area, is on the order of maybe 1 to 3%. Then we think that formula is actually going to be very, very accurate and saying that we think that this negative predictive value is on the order of greater than 95 to 99%. That is, if you get a negative test, you can be 95 to 99% certain that the test is accurate.
Okay, thank you. That's really, really important. Nigam, can you comment on what models are being used to predict PPE supply in the local areas such as San Mateo and Santa Clara counties?
While we don't have good models on predicting supply, we do have good ways to estimate usage. And I would particularly call out the work of David Schenker, which we just alluded to briefly a little while ago. What these models allow you to do is, given your hospitalized patient rate, given the rate at which you're discharging patients, new patients coming in, and your staffing plans, they estimate how much PPE are you going to go through in a given day. And from that, you can calculate how much supply you would need and then work with the government officials or your procurement departments to procure the needed supply.
Okay, great. Thank you. Bonnie, in recent news, it was stated that African Americans and those of Hispanic heritage are more susceptible to COVID-19. How are we taking precautions to protect our more vulnerable healthcare providers who fall into these categories?
That's a really important issue. I know that it's only been today that many places, and I believe New York State is the first, to actually start tracking race and ethnicity around COVID positivity. I've been talking to colleagues around the country about what we are going to do to understand why this may be happening. Now, it's possible that this may be resulting from socioeconomic factors. For example, we know that many of our underrepresented minority people in the communities that we live in are having to still go to work. They may live in more densely populated households. They may not have the capacity to protect themselves in the same way as the people with more resources. And so we know that there's a socioeconomic component. I know the county and especially the state today will be on a call talking to the state, the governor's office, to understand how we can do a better job at the state level to support these vulnerable populations. But we're going to also learn more about whether there is any other vulnerability in these people that we might be able to help them overcome. So this is clearly top of mind and something that we need to take into account if we are going to protect those vulnerable people and society as a whole.
Okay, thank you so much. Dale and Luann, how has the use of PPE for nurses and other frontline staff compared with that of other institutions? And what is that difference?
That's actually a really good question. We are monitoring our PPE very closely through the supply chain and Amanda's group. And we are monitoring it so closely that I think we have a good handle on it. I'm not sure how we compare to other institutions, to be quite frank, but I'm confident that we can get an answer to that and bring it back to this group, this forum.
Dale, anything else to add?
No, I would just echo Luann's comment that we've had just tremendous rigor in looking at PPE and then changing our protocols and guidelines based on PPE requirements coming out from the CDC. We've advanced on screening at the front doors of the organization to make sure our healthcare providers are safe. So lots of energy is going into this particular category with a lot of great experts.
Great. And I'd like to remind everyone that this information regarding higher risk healthcare providers as well as the latest PPE use guidelines are on our Stanford Medicine COVID website. And that's where you can get the most updated version of all of those guidelines. Nigam, how has Stanford and LPCH set up a symptom checklist in EPIC to compile data on all COVID positive patients? And I'm struck by how much data is missing in the CDC's MMWR reports, and it seems very difficult to pull data.
This is a great question, and this goes back to the need for accurate data. Stanford has been at the forefront of this, and we follow the CDC recommended flowchart for asking the questions that we should be asking to our patients. And right now they're recorded in a free text document, which we also have the ability to mine. In fact, we've been pulling the presenting symptoms of all the patients that we're testing and continuously calculating the probability of having a positive test given a certain symptom and a set of symptoms. And we've also published this publicly, this symptom profile, to help others to decide what questions are worth asking and maybe include them in the surveys and other kinds of studies they may be doing.
Okay, excellent, thank you. Dale and Luann, what has impressed you most about the nursing staff as they've responded to this pandemic?
So I would just say that I mentioned this earlier, just tremendous resiliency from our nursing staff. And we're having single digits, sometimes double digits call-ins, which shows that our nurses are committed to make sure that our patients and our community is safe, and also to support one another, which again is why we've been able to maintain the excellent ratios that we have in Stanford Medicine.
Wonderful. Well, I wanted to thank our guest experts this week. Thank you so much for your knowledge and your perspective. We very much appreciate you being here. And now we'll turn over to Stanford Medicine leadership for closing remarks.
Thank you, Andra. Paul, David, and I want to express our appreciation to each of you for joining us on this town hall today. And special thanks to Luann, to Dale, to Bonnie, and to Nigam for their presentations and their responses to your questions. We know that we've been in shelter in place for a long time, and we have a long time to go. We don't know exactly how long, but certainly until the May 3rd period here in the Bay Area. And we also know how confining that can be and how anxiety-producing that can be. For all of you, we want to thank you for your diligence. For those of you who still need to be in the work environment because you have direct patient-facing activities or because your activities have been determined to be essential for the overall enterprise, we thank you for the work you're doing when you're here, and we thank you for continuing to observe shelter in place when you're not here. And for those of you that are sheltered in place, please know that we're still with you, we're still connected with you, virtually now rather than person to person. But still, we hope in a very meaningful way. Continue to give us your feedback. We take that feedback very seriously, and we look forward to seeing you again next week at our town hall meeting. David?
Lloyd, thank you. Thank you for being here with us today. I appreciate everyone and taking the time, and especially our panelists. I will point out, as Dr. Shaw's data suggest, we are not seeing the uptick and the surge that others are seeing in other markets. And I will say my heart goes out to many around the country who are really seeing challenges with the number of individuals coming into their organizations, the shortage of various different items that they need to care for them. And that's certainly something that we're very attuned to. But I want to take a moment to thank you for the great work that you continue to do. We continue to see great work around our organization. I've done several shout outs, whether you look at our facilities team, our housekeeping team, what we're doing with our nurses, various different things that I think are so important to the work that we're doing, especially our PPE folks. We appreciate all the supply chain and what they're doing. Today I'd like to do a special thank you for what our IT colleagues are doing and actually our telecommunications teams. If you look at our numbers last week alone, both across our Stanford faculty clinics and our UHA clinics, we literally had 71% of our visits take place by phone or video. That's incredible. Think about when we talk about being digitally driven, we truly are able to stand that up and make sure that we're keeping our providers and our patients safe. We've also been able to stand up an app with Stanford partnering with Apple called the First Responders app that actually allows for paramedics, firefighters, policemen that may be having symptoms to be able to go onto the app and check and see whether they need to get a test. And then we partnered with them to do that test quickly if they need it. We also, Nigam mentioned that data is an important aspect. We've actually launched through one of our own faculty, Dr. Rusty Hoffman, a national daily health survey that now collects data on what symptoms are from around the country so that we can start to predict what hotspots might be with COVID. What a valuable tool that we have, and really is using some of the digital technology that's so pervasive here at Stanford. Again, a shout out to all doing the incredible work. We appreciate all that's getting done every day and all the great work. Thank you. Paul?
Thank you, David. As you heard from our panelists today, there are rays of hope in terms of what's happening with the virus, in terms of surge. We haven't seen the numbers that were originally predicted, and part of that is because of all the hard work you're doing every single day, every single shift. We have not relinquished our focus on your safety. That's very important to us, and as we see the numbers improve, we want to make sure that some of the decisions we've made to reduce our volume, to reduce the number of visitors that our patients can have, all of these decisions have been made with an abundance of caution. However, as we've reduced that volume, many of you are concerned what that means for you personally. You'll be pleased to know that our next town hall, next week, next Thursday, is going to feature our HR professionals to really begin to address some of those concerns you may have about time off and childcare and some of those other issues. So stay tuned for that next week. So I'm going to punt back over to Andra.
Alrighty, great. Thank you all. Thank you very much for attending our town hall today. We look forward to seeing you next time. Stay safe and healthy.